Welcome to Core Ultrasound Image Review
Yep.
number 13.
13. It's a lucky number 13. I'm excited. I think that's a baker's dozen.
Yeah, clock strikes 13, something like that.
That's right. So let's talk about some stuff here, dude.
Yeah, I think we have some good images to review.
It's a chunky lung.
I know
dude.
you love lung.
You know I love lung. It's so chunky.
It is. There's something wrong with that.
Something way wrong. Now, this was something that I think one of the residents did. I don't think this was me. There's a couple of things I love about it. The first thing is that the pleural line is really opened up. That means that the probe was in between. It was like parallel to the rib space, which is a huge plus.
What do you mean by opened up?
So normally you'd see like a rib here and a rib here with like a pleural line and then a shadow and then a pleural line. But I see all pleural line right here, which is great. A little bit of rib with a shadow down here, but a really good view of like a chunk of that pleural line. Yeah.
I also want to give credit to whoever labeled this because that's
thank you.
really important. I don't think we always take the time to do that.
Yeah.
But if you are saying one side is different from the other, like let us know what side it is.
Yes, please.
Awesome.
Yeah. I mean, it helps with like us when we're image reviewing, but also like if you have one of the people you admitted them to, they're going to be able to like kind of track this progress. And I will tell you from personal experience that COVID lung, which is probably what this is. I don't actually know what it is. Probably what it is. You can actually see these lesions get worse and get better with symptoms. So it's actually helpful to be able to track and be like, this lesion is this way today, and tomorrow it's worse.
Left, right, base, yeah.
Exactly.
So, but what we're really seeing is this right here. I mean, that's where my eyes go.
Yeah. That's a subpleural consolidation, which is
Awesome
it's really
example.
It's a silly name. Have you ever thought about this? Like
Subpleural, which could be anywhere in the lung.
Every pathology that you can see on the lung is subpleural. Like a pneumothorax is technically it's right beneath the pleura, you know. So it's kind of silly. So I don't know. Like you talk to, I think it was Volpicelli that I was talking to one day. He's like, "Don't call it that." And I'm like, "Yes, sir," but I still call it that because everybody else does. Yeah, that's what everybody else does.
But this is important because there's a pretty wide differential for this. Is that
huge differential? Yeah, I mean it could be anything. I mean, COVID's one.
Yeah.
You could have PEs that can cause these subpleural consolidations.
Pulmonary infarct.
Mm-hmm. Pulmonary infarct can cause it. Septic emboli, which is one of the more common ones.
I feel like we see that.
Yeah, especially like where we work. Pulmonary contusions can cause it.
For sure.
Atelectasis can cause it. Early bacterial pneumonia.
Some kind of B lines past the subpleural.
Yep, you're talking about right here.
Yeah.
Yep, exactly right. And we're seeing some B lines kind of scattered over here too, which to me, if I see surrounding B lines, that makes me think more that it is an inflammatory process rather than like PE. Like PE itself isn't necessarily an inflammatory process.
Like you gotta nail this one spot.
Exactly. Like this one spot is messed up as opposed to this where like this whole section of lung is messed up. It's just more messed up here.
Yeah. So the take home from this one is that it is a finding, but you gotta correlate.
Yeah, that's huge. I love you. Thank you for bringing that up. So next time, though, can you say, this is my favorite thing to say, is it's a tool
in your quiver and an arrow
in your toolbox. Yeah, yep, exactly right. All right, let's do the next one. Ugh.
Yeah, wow.
Yikes. Wow, it looks like it's like a little bird's beak, a little beep, beep, beep.
He's just trying. Yeah.
He's just trying. Feed me some inotropes. Yeah, this is a really bad heart. Super dilated LV, pretty dilated
Big
LA.
LV cavity.
Yeah, and that mitral was barely moving at all. I remember when I was a medical student, I didn't really appreciate that the valves don't like mechanically do anything. Like all they're doing is moving based off of how much flow is going through them, right? So that's like a surrogate marker there.
Yeah. That's what he said. Okay, now this is a phrase that if I stole it from you,
probably not.
Or anyone else, let me know. But my eye goes to the left atrium more and more, and in my mind, I've started calling it the A1C of the heart.
That was definitely not me. But I like that.
I probably stole it from someone. But it's one of those markers that as we see the LA dilate, it's either, obviously you got some mitral regurgitation or it's part of their diastolic dysfunction that is progressing over time. But yeah, this heart's not looking too hot.
Yeah. I like that you brought up the diastolic dysfunction thing because it's something that like I nerd out on is like how the heart responds to like chronically elevated afterloads. But it's not like, I don't know, a lot of people talk about it.
We don't talk about it that much.
Yeah, that's true.
But definitely this. I can guarantee this person has some diastolic dysfunction.
Yeah. Oh yeah. Of course.
Now, where's your stock in EPSS?
So I think that the EPSS is great if you don't have a whole lot of experience using your eyeball method. Now, the EPSS stands for E-point septal separation. It's the distance between the septum and then the E wave, which one of my favorite things to tell like residents and medical students when they're like starting out is, did you know the mitral valve opens twice in the cardiac cycle? Yeah, and everybody all freaks out. But here, look, if we look right here, this is the first time it opens, which is the E wave. And that's the first pressure difference right between the atria and the ventricles. And then this A wave is actual atrial contraction.
That's right.
Yeah.
Now, we're not going to get into it. It always confused me. We use the EPSS, and we're looking at a diastolic portion to make a systolic assumption.
That is odd. You're totally right.
Let's just leave it be.
We're just going to leave that. That's my brain's hurting already. But the number is less than 0.7 is good. Greater than 1 centimeter is bad.
Yeah.
Gray area in between.
Yeah.
That's usually the cutoffs.
I think, a lot of us work at our eyeballing. And this, for me, the EPSS, even though I don't measure it very often, I start eyeballing it and I add that to my global picture of the heart.
Nice. Brilliant. Oh, so are you doing EPSS like most of the time?
No, but okay. My eye does look at that mitral leaflet.
Yeah.
Anterior leaflet.
Of course. And one thing is actually Jason Bowman, who is one of our former residents, who is a critical care fellow at UK now. He showed me this, and it's so elementary that I was like, obviously he figured out he's really good at like simplifying things, but he doesn't use M mode. He just freezes it and cycles back and then just like physically like measures it from there to there. So you don't have to use M mode, although I will say I kind of like the M mode because I feel like
higher resolution, but you could get a much quicker answer probably.
Yeah.
Probably.
Yeah.
We just get real fast out on the machine.
That's true. Like Jason Bowman. What we got next?
Let's see what we got next.
Oh, no.
Yeah, I don't know who found this.
Oh, no.
They did a patient right.
Yeah, that's crazy. You're talking about this gallbladder over here, right?
Oh, yeah, totally.
Is that what you're talking about? This gallbladder might be a little dilated,
this back pain.
Yeah, it might be a little dilated.
Back pain is the gallbladder.
Yeah, my favorite thing to say is I'll yell, there's a flappy thing in the aorta, because there's not supposed to be like any flappy thing, right?
Yeah.
There's no valves in the aorta. You should never see anything in the aorta, and we're seeing very clearly. Yeah.
Don't get that wrong.
Don't get that wrong. Yeah, it's pretty good. And this is enough, right? I mean, I like doing the long axis view because I love seeing the whole like string or whatever. Yeah. But this is sufficient to rule in a dissection. Huh.
So this was probably a little bit of a surprise.
What is that? Is that like a aorta?
So we're
kind
definitely
of like a weird aorta.
The first thing that we have some anechoic something.
How about this right here?
Yeah. And that looks like bladder.
Okay. Bladder. Maybe some bowel right here.
Yes.
Yeah. All right.
The question is, what is this? Vessel?
If this is a bladder, like you say it is, this is a connecting structure. This has to be a bladder diverticulum.
A bladder diverticulum.
Yeah.
I'm not sure if I've ever seen one of those.
Today I saw one right here.
Right
now on this. Yeah, I guess probably what would cause it is like chronic urinary retention. Just trying to think about it, like.
Yeah, I'm trying to wonder what the clinical ramifications of finding you.
It looks cool.
Predisposed to UTIs?
It must be, right? It'd probably be hard to empty this.
Does this bladder wall look thicker to you?
Yeah, it looks way thick. You can actually like almost like see. It's probably like a muscular layer there and there, yeah, because it's like 3 layers. Almost like when you look at a contracted gallbladder, you know how you can. Oh, you actually see it right there. See, there's like a layer, and a layer.
Yeah, totally.
It's weird. Ooh. Oh.
Flying object.
It's a flying object in there. This
that looks like Saturn. That is
It is Saturn.
Planet. Look at that.
It is an ultrasound of Saturn.
Yeah.
That is. It's always interesting to me to see this because if the Foley, which that's what this is working correctly, I guess you shouldn't be able to see the bladder. But I think what's happening is I think the Foley tip is like stuck on the wall. Mm-hmm. And it's probably not able to suction until
because what you're saying is it's not decompressed all the way.
Yeah. Like I feel like a Foley should mean that there's nothing in the bladder because isn't it just like continuously drain?
Yeah.
Yeah, this is cool. I mean, it's just something to know. Like that's what
I
it
love
is.
working with learners because there's always someone's first Foley balloon
that's
that
right.
they see.
Yeah.
And like you can see the light go off in their head. Like, oh, that's a Foley.
That's a Foley. Yeah. And I've had this is a perfectly normal Foley, but I've definitely seen it sometimes where we will get, they'll put it in the Foley and get some urine back, and then it kind of gets clogged or whatever, and you can actually see the Foley bulb like stuck deep to the prostate, or distal to the prostate. Yeah. And also one thing that's pretty cool is it's somewhere. I don't know exactly where it is, but I know that there's a picture somewhere of somebody popping the Foley balloon, like because it was like they couldn't deflate it because it was like messed up or whatever, and you I think you slide the J-tip from a central line.
Yeah.
I think you slide that into it, like, but the back end, not the J-tip, but the back end, put it in there and just force it, and it'll pop it, and you can just see it like explode.
Awesome.
It's pretty sweet.
That's awesome.
Oh, you put more lungies in here for me. I like lungies. Those are my favorites. So this is the same thing, right? So this is like in between the rib space. Let me grab this right here. So it's like you're basically instead of being like this, you're like this, like in the completely like parallel with the intercostal space right there.
Right. So what are we seeing?
So this is another subpleural consolidation. It just looks different.
They're bigger.
Yeah, they're bigger. So it's this, and towards the end of the frame here, wait for it. You can almost see it kind of bulge out a little bit. See how like this is it right here. Mm-hmm. The fact that this is so round and there's no surrounding inflammation makes this pretty much cancer. Like that's usually what this is. Yeah. Because it's not any kind of wedge shape. Because you think
you're not having this reaction of
interesting. Yeah. And the history is super important, right? So like this is somebody who's smoking history, weight loss will have the cancer type symptoms, and you see this in the lung, you're like, oh shit, that's cancer.
Wow.
Yeah, this is what it looks like. Although I will say that I'm not gonna I wouldn't just get an ultrasound.
Yeah.
With such like an important diagnosis and just like say like it's follow up outpatient. Yeah. I'd get further imaging for sure to confirm that, but this is very likely to be some kind of peripheral lung cancer.
Okay.
Unfortunately. Cool. Yeah.
Are we wrapped up?
Yeah.
Is that good?
That's good. I think that was a good one. Yeah. For number 13?
Yeah, I mean, this
is perfect.
Lucky number 13.
Yeah, that's right. 14 will be even better, probably.
14, I cannot wait.
It'll be good.
The anticipation is killing me.
I can't wait. Cool. Thanks, man.